So welcome back. This is our second portion of your orientation. We're going to start out with, again, rules and regulations, but we're going to start out with the governing body, the governing board. For Phoenician Hospice, that is Dr. Levy, Valerie Woodworthy, and Phil Gallinero. They are the governing board. They are the developers of Phoenician Hospice. They are the ones that designed Phoenician Hospice according to the rules and regulations, right? Let's keep that straight. So know that even the governing body is ruled by regulations, by Medicare regulations, and that's where the regulations actually start. They start with the governing body, what they are required to do, the expectations, who they oversee, what they oversee, how they oversee it, and what documents need to be turned in when, quarterly, biannually, annually, finances, all of that is the governing board's responsibility, but it's our responsibility to get the information to them so that they can turn it in to the appropriate financials or Medicare or OIG or whoever requests it. So realize that even they are regulated. They're the very first regulation. I love it. Start at the top and work it down. Not that anyone is any less important, but you start at the beginning, and that is the governing board. When 9/11 happened, we're going to move on. When 9/11 happened, it was a tragedy for all of the United States and the world, most of the world. When 9/11 occurred, the first responders were phenomenal. They were there, and they rushed in. I still get tingles. They rushed into those buildings and climbed those steps and carried people out as much as they could. They died with some of them. We lost them, and we're still losing some of them because of the smoke inhalations and the toxins that they inhaled and the wounds that they incurred. Through 9/11, all medical people were called on high alert, and the hospitals were on high alert. They were opened up. They were triaging. They had tents up to triage and take care of the wounded people. The one area, two areas actually, that were not called out were home health and hospice. Two areas that could have been so valuable to the care of those people that were injured. Home health nurses have such a huge expanse of knowledge, whether it's IVs, wound care, you name it, they do it. They go to the home and they do it. Hospice, for those that are not going to make it, we have such a wide, we do wound care also. Hospice does wound care, serious wound care. We can do IVs. We know how to do all of that also, but we can also get them comfortable. We can also let the first responders and the doctors that are there know this patient needs Medicare or morphine or oxy, something for pain. This patient needs this or that to keep them comfortable. And our social workers can help notify families and keep them up to date on what's going on. Our chaplains are there for comfort, but we weren't called on, and no one thought to be out there. And so through that is this. I don't know, does this show? Can you all see it?
Mm-hmm.
This is now required. It is also in this regulations book, my book, the Emergency Disaster Plan. Through 9/11, when it was realized that there were two important areas that were not called upon, we are now called upon. And so this has the federal regulations and the federal plan to be available. It has our Arizona State Department of health services, our plan, and then it filters on down to what are we going to do as hospice? How can we help? What can we do? Last year, since it was our first full year of being a Medicare approved hospice, we had fire drills. Okay, that's easy. I went through going, fire in the kitchen, fire in the kitchen. And so then the timer started. Doors were shut, making sure people were out of their offices, right? Not shut in, but making sure that everybody get out and go to the appropriate meeting space. That has to be done quarterly. But more importantly, we had a tabletop emergency, which was okay for the first year. And we did a tabletop disaster. And that was done with a call tree, who's going to be notified, who's going to be in charge, who's going to take the notes, who's going to be doing all this leg work, who's going to send who where, what are this nurses going to do, what are these nurses going to do, what are the aides going to do. Even at 9/11 they needed the aides, the CNAs, so valuable. But they weren't called, and now they are. We're now called to do our duty. And we're part of this, and it's an honor to be part of that. This year, we will be working with the first responders in a community-based emergency. Could be a plane crash, could be a disaster at the nuclear base, could be a hospital problem, could be a terrorist. We don't know until we're called, and we get there, and we'll be getting the information as we go, but our call tree will be enacted. We will be first making sure that our patients are cared for, because that's our number one. Where are our patients? Are they in an area of disaster? Do they need to be moved, or are they okay for now? If they need to be hospitalized for oxygen, then let's get them moved. We'll get transport and get them moved. They're our patients. We're responsible for them. But then we're also responsible to go do care wherever the disaster is. So this will be our first one to join in on. We've been to a meeting in December, collaboration of California, Colorado, New Mexico, and Arizona. So it could be anything. We don't want a disaster to happen, but we need to be ready, and we need to be trained. So that is now a regulation, and home health and hospice are now involved in disasters. I sound excited about that. I am, because it's good to know that we're needed. It's sad to know that we're needed. That's painful to know. It's painful that we have disasters, but disasters do happen. Could be something like a flood. With all the rain tomorrow, rainy day, right? All day, heavy rains. Up north, they could be going into a disaster mode now. Some of them are getting up to 4 foot of snow. Are they ready? Are we going to get called for that one? I don't like snow, I hope not. But I will go. But I will be in a warm car and tell other people what to do. I'm kidding. We will all do our part. PAC. That's a partnership in the community. And so we have partners, leadership in the community. And it could be a pharmacist, it could be store owner, it could be durable medical equipment business. Leadership in our community in Maricopa County, because that's who we service, is Maricopa County. So leadership, and there's usually 6 to 8 people that come. And of course it's after hours, so we offer food. You offer food, people will come. We feed. So we give them a report on what we have done the previous year. We started, we did this, and now here we are. And we're going to move forward, but we need to be more involved in the community. We need to know what is needed out there. How can we become involved? How can we participate? Is it health fairs? the Alzheimer's walks, Parkinson runs. There's all kinds of things that hospice can be involved in that now we're going into our toddler stage and we're ready to get out there and be involved. It's these members of the PAC team that will help guide us in that area. And maybe even say, you know, what you're doing here doesn't really fit in our community. Oh, but it does fit here in Glendale. So let's see how we can wrap it and make it work on both sides. So it's just a really informational type meeting where we all come together and make a plan. And then we can meet again the following year. Usually, if you meet biannually, then we have a report to give of this is what we did since you recommended these changes, and this is where we are. Where can we go from here? How can you help us? How can we help you? How can we be involved? How can we be a bigger part of this community? The next area is regulatory, again, contracts with facilities. We have different levels of care that we offer our patients that are regulated. GIP, which is general inpatient care, and that's when the patient needs a higher level of care than we're able to give them in their home. They have something going on, whether it's acute pain or nausea and vomiting, something that no matter what, we can't seem to get ahead of it and get them comfortable. We document everything that we've done, and if we're still not getting them to the comfort level that they need to be at, and we need them to be at, and for their family to be okay with, then we will offer to put them in an inpatient unit. Preferably it would be another hospice that has an inpatient unit, because then you have hospice nurses and skilled nursing assistants that are caring for the patients, but they're also able to go to a skilled nursing facility and get the care. So we had to have a contract to place them there, and there's several stipulations. One is that any place that we place our patients for GIP or respite has to be Medicare approved. So if that facility, if that nursing home is not Medicare approved, we cannot use them. They have to go to a Medicare approved facility. If they're going in for general inpatient with something that's going on, pain usually, that we can't get in front of, then there has to be a registered nurse on staff 24/7. That's a requirement. If you don't have that, then we can't use them. The registered nurse doesn't have to be the only one taking care of the patient, but the registered nurse has to be there to do a total assessment, a comprehensive assessment, and making sure that the right orders are being followed. We collaborate with them. We have a plan of care that's developed with them. This is what we feel needed. Our nurses go there daily, and sometimes more often, to make sure that everything is being done that needs to be done. Our doctors, their doctor is being kept in touch with for orders, for care, and changes of orders. Respite care, I brought that up. Respite is for patients that reside in their home, or in their family member's home, or in a friend's home, but not in an assisted living or group home. They're residing in a residential home. They may have a paid caregiver, or maybe their daughter or husband or wife is caring for them. But at some point, those caregivers get so tired and they get worn and weary and they can't do it. They need a break. So we talk to them about respite care, up to 5 days. Give you a break. You can go to the beauty shop, you can get your nails done, you can do some shopping, go to a movie, go to bed, stay in your pajamas for 5 days. spoil yourself. We arrange that, and that's also in a facility that is Medicare approved. They are still treated as though they're in their home. They don't need the extensive acute care that's being given to the GIP, general inpatient person, but they still get all the cares that they need. 9 times out of 10 when this happens, I'm going to backtrack. When this happens, when a patient goes in GIP or respite, in the contract it states that the family members can come and be there 24/7, and they will be treated respectfully, and there's no limit, because some people have large families, so you may need to limit how many can squeeze into the room, but that's just part of hospice. It's all about that. So that's in the contract. So that being said, when a patient goes in on GIP or respite, 9 times out of 10, whoever's taking care of them ends up going in with them, and there's a bed or a couch that pulls out or a cot that rolls in, and they stay right there with them. But they're there as the son or daughter or the spouse. They're not taking care of them. They're just able to be with them as their loved one, as their family member or friend or significant other. They're able to be there with them and not have to do all those cares. Someone else is giving them a bath. Someone else is taking care of them. Someone else is fixing them food and bringing it in and feeding them if they need to be fed. Someone else is doing all of that. And that gives them the break, yet they can still be with them. And I just think that is really the epitome of hospice, because we take care of everyone. So there is a contract drawn out. It's all very legal. Everyone signs it. It's gone over, and part of the contract is that someone from hospice, usually me, but one of the nurses, will give an in-service on hospice care. Hospice 101. This is what we do. This is the expectations. And this is what we will do. This is what you will do. And this is how we will work together as a team for your resident, our patient, or our patient coming in for respite. And it's all very legal, but very much a partnership when that happens. And usually they're one-time contracts, because at this time we don't have anyone residing in a skilled nursing facility. We do have patients in assisted livings and group homes. Group homes are less than 10 residents. Assisted livings are more than 10 residents and can be quite large. Skilled nursing facilities are exactly that. They require a high level of care. They're not able to take care of themselves, and the family members aren't able to take care of them. So they live in a skilled nursing facility. They used to be called nursing homes. But as they grew and regulations grew and they improved, they're now skilled nursing facilities, but they offer the same things. They offer nurses, they offer CNAs, they offer social workers, and they have chaplains. So how do we work together with them and not override, and Medicare gets double billed? That's what the contracts are all about. So that's a facility agreement and contracts. We have contracts with our partners that we'll go into in a few minutes. We have an outreach program, and this is something that's very special that Dr. Levy has decided to set up, and it's working on both sides. It's working with our hospice patients that have stabilized, and we call it, they've stabilized and they're allowed to graduate. And that's a great thing. It's always a great thing to graduate. Now, maybe the disease, obviously the disease is probably not going to go away. I shouldn't say obviously, but more than likely they still have the disease and the disease process, but they've stabilized and they're comfortable and they aren't declining. And so when this happens and we observe, and if it continues that they're stable, then we graduate them and they're placed on the outreach program. The outreach program has a leader that will call, and also other people that will come in and they call these patients that have graduated. How are you doing? Is there anything you need? And perhaps a social worker may go out and visit if it's felt that that may happen. Outreach program also is on the mobile care unit, where you call and check with Dr. Levy's patients, see how they're doing. Is there anything they require? Can I set up an appointment for you with your nurse practitioner or physician or physician's assistant? And that way, there's always attention given to the patients and to the caregivers, the families, because families get overwhelmed, whether they're on hospice or they're just someone at home that they're taking care of, a loved one. That care is 24/7 and they may forget something. So that's a great reminder. It's an outreach. We're reaching out to help you. How can we help you? It's an outreach program. We're hospice. Hospice has death and dying. And so when you have people dying, you need to have mortuaries. And we have a list of mortuaries everywhere in Maricopa County. They're all in our electronic medical record, our EMR, which is Consolo. So when a patient dies, hopefully before that patient dies, that discussion has taken place with the family or medical power of attorney or the patient themselves as to having everything already set up, and the social worker will take care of that. Let's go over everything. What do you want? Let's see how we can get this arranged so that your family doesn't have to do it. Or the medical power of attorney will take over and do that, but we will offer them a list of the mortuaries in their area. Being Arizona, a lot of our patients have come from another state. New York, Massachusetts, New Jersey, Ohio, Kentucky. I'm not going to name all 50 of them, but they come from all over. And so they've already made arrangements to be buried with a loved one, or maybe they already have a cemetery plot. So then we have all that information, and when the patient dies, we notify the mortuary from whatever state they want to go to be buried and have their funeral. They make the arrangements, notifying the mortuary here as well as we do, but they work in congruency with each other to get that patient taken care of, their remains taken care of, and sent back to the state in a respectful manner. So that's all in, and the social worker takes care of that. The communications board is Tiger Text. I don't know if you're familiar with Tiger Text. It is a secure texting line, and that's where we do all of our communicating. That's where patient reports are sometimes given. If a patient has had a fall, there's a incident area on Tiger Text so that everyone's aware. If a patient has transitioned and is now going imminent, they step up their visits. All of this is, if there's an admission or a death, all this comes through Tiger Text. And so everyone can then go into action and do what their part is to make sure that the family and the patient are supported and cared for. Education. I really need you to know that Phoenician Hospice is big on education. It is continual and constant. Even when you don't know you're being educated, you will be educated. It'll be education on documentation, or it will be educated on phone etiquette, or it will be education on disease processes. There's always education going on. So if we don't educate you, then we're not offering you the proper tools to do what you need to do. So that is our job, to make sure that you have all the education you need, which is part of your tools of your trade, so that you can go forward and take care of what you need to do in your position. We have employee and volunteer in services. In services is another word for education. And we will call everyone in, discipline specific, to have education. The education is general and it's also job specific. Know that everyone that works in hospice is required to have 2 hours a year in hospice education. This will count for 1 hour, your orientation. You will receive EMR and Consolo. Consolo is our electronic medical record, EMR, and that's where everyone does their documenting. You will receive that training, and that's ongoing because it's always being upgraded. You'll receive documentation training. You're not thrown under the bus. The RNs will receive their job-specific responsibilities and training. The aides, home health aides, will also receive their training, home health or hospice health aides, and their plan of care. The nurses are responsible for developing a plan of care for the aides. Aides are not allowed to do anything outside of their plan of care. They can only do what's on that plan of care. If the patient requests something outside of that, then they must text their nurse or call us here or text us. We'll look at that patient's medical record and say, yes, go ahead and do it. We will adjust the plan of care so that you can do it. But if it's a COPD patient and they want nails, what is that aroma going to do? Or odor. Some of us call it an odor. So, it has to be very specific. Visit frequencies. If you're required to visit someone twice a week, I'm the one that will check that. Are you doing your visits twice a week? Are you documenting that those visits were done, and is your documentation appropriate? Medication reconciliation. Every week you will do a medication reconciliation. That means looking at the meds, counting how many pills or how many milligrams or mLs are in the bottle, and making sure that the meds are reordered so that the patient never runs out of their medication. We don't ever want that to happen. Psychotropic consent documentation. If they're on psychotropic medications, anti-anxiety medications, things to keep them calm, lorazepam, Celexa, those kind of medications, then we have to have a consent to give those. That's a regulation that the MPOA or the patient or whoever's in charge will sign that form stating that yes, it's okay for this patient to have it. Even if they were on it before they came on the hospice, now they're on hospice, we're going to be ordering it. We need that consent. We have care plans. We don't operate without a plan. You can't build a house without a plan. So there's a care plan for everything we do. And for every care plan, there are interventions of this is the plan and this is how you're going to get that plan done. This is how you're going to accomplish this care plan. Documentation requirements. You will be trained extensively on the requirements of documentation. Medicare wants us to paint the picture. So, as evidenced by, we see this as evidenced by this. This is occurring related to this. We have to paint the picture to show that they're hospice appropriate. There's IDG meetings. I went over that a little bit earlier, interdisciplinary group meetings, and that's where all the disciplines meet and discuss their patients with the medical director. And the care plans are either changed or enhanced, or that care plan has been met or no longer appropriate, and we need to develop a new care plan. And this is how the patient was 2 weeks ago, and this is how the patient is now. If it's a recertification period, which we'll go over later, this is how they were at when they were brought on, when they were admitted, start of care. This is how they were at this last certification period. And this is what I'm seeing now, which makes them still appropriate for hospice. But these are things you're going to learn in your education. This is just the orientation to let you know these are the things that we do. With that, we'll take another break and we'll meet back here in 10 minutes.